Good afternoon and welcome to our medical lecture series. I'm Dr. Galit Hakim, Assistant Vice President of International Healthcare Partnerships and Insurance Development at Baptist Health International. It is my pleasure to welcome all of you to this informative presentation. I would like to extend warm greetings to our friends across Latin America, the Caribbean, and everyone joining us today. During this interactive presentation, you will have the ability to ask questions via the Q&A feature located on the bottom of your screen. I will be your moderator for today's lecture. This afternoon, I have the distinct pleasure of introducing Dr. Carlos Sanchez-Correa. His presentation is titled Introduction to General Surgery, Urological and Technologies Used for Patients' Care. Dr. Carlos Sanchez-Correa is a urology specialist at Baptist Health. He treats male and female urinary conditions, complex and recurrent urinary tract infections, incontinence, kidney stones, pelvic floor disorders, erectile dysfunctions, benign prostatic hypertrophy, as well as penile, prostate, and testicular diagnoses. In addition, he also provides care to patients with bladder, kidney, and prostate cancer. Dr. Sanchez Correa earned his medical degree at Ponce Health Science University in Puerto Rico. He completed his residency in urology at Louisiana State University, during which he served as an investigator on a clinical research study that utilizes the cost burden and risk profile of drainage devices in pediatric patients with bladder disorders. Dr. Sanchez Correa is a member of the Alpha Omega Alpha Honor Medical Society of the American Urological Association and American Medical Association. Thank you so very much, Dr. Sanchez Correa, for accepting our invitation. Let's all give a warm welcome to this great man. Thank you, Dr. Sanchez.
Oh, my pleasure.
You
So,
may begin your presentation whenever you see fit.
thank you, thank you. Let me share this real quick. Okay. I hope that everyone is able to see the
We're,
presentation.
it's perfect.
So, um, I'm gonna start very broad and then slowly go down to more specific subjects as at least in my experience, like it was with myself, I didn't really know what urology was until I got to my third year of medical school, that you actually get some exposure to it. So that's why the title of the presentation is Introduction to General Urology and Technologies Used for Patient Care. Um, Sorry, give me 1 second. And so when we talk about urology, urology is a very broad subspecialty, as within the subspecialty of urology, there's further subspecializations. So you have the general urologist like myself that we treat a little bit of everything, but then you have the fellowships such as the urologist oncologists, which are urologists that only manage cancer, either prostate cancer, kidney cancer, testicular, adrenal cancers, and so on. You have subspecialty physicians that do female pelvic medicine and reconstructive surgery. These are urologists that mainly focus their care in helping female patients, such as stress urinary incontinence patients, urge urinary incontinence patients. And within this fellowship, there's also something that is called neurourology, as they do a lot of training to evaluate the neurological component behind voiding or urinating. There is a fellowship in male fertility or andrology. These are the physicians that help couples that are struggling to be able to achieve pregnancies, and they focus more on the male partner. We have reconstructive urologists. These are the urologists that you see very often in trauma centers, like after patients have motor vehicle accidents, gunshot wounds, stabbings, that they need some sort of urologic reconstruction, either bladder reconstruction or ureteral reconstruction. You see the endourology subspecialty. These are physicians that it used to be mainly focused on kidney stone surgery and advanced kidney stone surgery, but that this subspecialty has grown, and now you see a lot of minimally invasive robotic surgery placed into this category as well. Obviously, we can't forget the pediatric urologists that help and treat all our pediatric patients. And there's a little bit of a niche subspecialty or fellowship, which is the renal transplant that also goes under urology. When it comes to what do general urologists do? So we see everything from the adrenals all the way down to the testicles. So that's why I wanted to divide it up in the very specific anatomical area. So we manage both medically and surgically upper urinary tract conditions such as adrenals and kidneys. We also focus on the lower urinary tracts, which include the bladder, the prostate, and the urethra, and the reproductive organs, which obviously includes the penis, the vagina, testicles, and also includes testosterone deficiency management. And for some, especially the reconstructive urologists, this also includes gender affirming surgery. When it comes to upper urinary tract pathologies, so here we're going to see both benign and malignant lesions. We're going to see the incidentalomas, which is nothing else than whenever a patient gets abdominal imaging, they find a mass incidentally on the adrenal gland. That's why it's called an incidentaloma. Those could be either benign or malignant tumors. So they could be managed by a general urologist, or they could be managed by a urologist oncologist. When it comes to the renal pathology, we have renal cystic disease, we have solid tumors, we have stone disease, we have infections such as pyelonephritis, and we have trauma, either penetrating trauma or blunt trauma. When it comes to ureteral pathologies, it's very similar to renal pathologies that we see stone disease, we see malignancies, but we also see stricture disease and congenital conditions. Congenital conditions such as there's a certain percentage of the patient population that can be born with either mal-rotated kidneys or poorly positioned kidneys, you could say ectopic kidneys, or they can also be born with more than one ureter, and all of those pathologies can come with their own complications, such as increasing your risk of urinary tract infections, increasing your risk of ureteral stones, and all of those things can lead to a compromise of the renal function long term. When it comes to bladder pathologies, which is one of the most common organs that we work with, we see malignancies, we see stone disease, we see urinary tract infections, voiding pathologies, and this is a very broad term because they can be both neurological in nature or non-neurological. And like with any other organ, we can see trauma. Prostate pathology, this is the most likely the leading organ in any urologist practice. And it's focused, basically divided into two different categories: benign conditions, which is what we normally all call like benign prostatic hyperplasia, or we have malignancies such as prostate cancer, which is the second most common solid tumor in males. We also have urethral pathologies, which is very similar to ureteral pathologies, that you can have malignancies, you can have stricture disease, you can have infections, and you can have trauma. So, and finally, when it comes to reproductive organs, we focus on the penis, the vagina, and the testicles. When it comes to the penis, the most common things that as a urologist we see is erectile dysfunction, trauma, or Peyronie's disease. Erectile dysfunction, as we all know, is a very common pathology that as time goes on is being seen earlier and earlier, and that is always that is multifactorial because of sedentary lifestyle, low testosterone levels, poor poor diet, all of which affects your vascularity. Peyronie's disease is another very common condition that we see. The easiest way to explain it is just a pathological penile curvature. And this happens, it could happen because of small microfractures during intercourse that the healing process is not the most appropriate, and it leads to scar tissue, which then leads to that penile curvature. When it comes to vaginal pathologies, from a urological standpoint, we focus mainly on pelvic organ prolapse and incontinence, both urge incontinence and stress urinary incontinence. And when it comes to testicular pathologies, the most common things that as a general urologist we see are hydrocele, varicocele, and infertility management. And varicocele and infertility are closely related, but they're not the same thing. So when it comes to general urology, which is going to be the main focus of my presentation, the most common pathologies that we deal with is benign prostatic hyperplasia, stone disease, overactive bladder or urinary incontinence, urinary tract infections, erectile dysfunction, and the three most common cancers that we see is prostate cancer, bladder cancer, and renal cancers. When it comes to management of benign prostatic hyperplasia, one of the beautiful things about urology, especially general urology, is that we're one of the few surgeons that we practice a lot of medicine or medical management. And when that medical management is not enough to achieve a good quality of life for our patients, we're the surgeon that can assist the patient in improving their symptoms. So when it comes to medical management, we use medications such as the alpha-adrenergic blockers, which is basically a medication that relaxes the tissue inside of the prostate to limit that outflow obstruction from the bladder out and allows the patients to void a little bit better. We have the phosphodiesterase 5 inhibitors, such as the Cialis, the Viagra, or the Levitra, which are medicines that are normally used for erectile dysfunction, but they've been shown to also work similarly to alpha-adrenergic blockers and relaxing that tissue and helping patients void a little bit better. We have the alpha reductase inhibitors, such as the finasteride or the dutasteride, which are medications that prevent the conversion of testosterone to dihydrotestosterone, which you can think of it like the fuel source for the prostate's growth. So what we're doing, we're slowly starving the prostate and slowly shrinking the prostate, and in that way limiting that outlet or that mechanical obstruction that the prostate is presenting to the bladder. But once those medications are not helping the patient achieve the goal that we have set for them, or that they have set for themselves, or if the patient does not want to continue any medications, there's always options for surgical management. The options are either open surgery, depending on the prostate size, versus endoscopic or minimally invasive surgery. And this is where urology tends to thrive on, because we are usually in the forefront when it comes to technological advances. So we have a lot of tools to be able to help our patients. Here we're seeing one of the most traditional surgical interventions, which is the transurethral resection of the prostate. In this picture, we're seeing that we place a small camera through the meatus and the urethra, go all the way into the bladder and get to the prostate, and then use a heated loop that basically just carve out that excess obstructing tissue that is leading to bladder outlet obstruction. And here we can see a little bit about what we call technological advances. In the first picture of the top, we're seeing the use of a holmium laser fiber, which is the same laser that is used for management of kidney stones. And here you can see that the procedure is also done through the urethra, so you don't have to make any abdominal incisions on the patient. And in this approach, you can see in the picture, you're slowly peeling away that excess tissue while leaving the prostatic capsule intact. On the lower left picture, this is one of the technologies that are most commonly used for either larger prostates or for prostatic cancer. That's it's called the Da Vinci robot. Is one of the most efficacious, minimally invasive tools that we currently have for management of prostate, either cancer or BPH. And next to it on the right side, that's one of the newest tools, which is the single port robotic surgical system, which is, as you can see, you see the patient here on the bed with the robot attached to the patient, and then you see the surgeon operating the console from the console away from the patient. And one of the beautiful things about this technology is that, as you can see, there's two people, there's two consoles. So this is a great tool for residencies, so you can for learning, because you can actually partake of the surgery with your attending physician at the same time and really learn how to perform a successful surgery. When it comes to management of benign prostatic hyperplasia, we have the Resume, which is basically injecting hot water vapor into the prostate, which leads to proteins to denature and then the cell lysis, and then you see that the tissue will eventually slough off. This is a technique that can be done either in the clinic, or it can be done in the outpatient setting in the operating room with some sedation, which is very beneficial for patients that can't really tolerate general anesthesia. The lower two pictures there, those are showing a technology that has been in the market for not that long, I believe like 7 years or so, which is called the aqua ablation. In this technique, you can see on the first picture on the left that we have a very nice picture of the prostate, and with the probe all the way in. And then on the right side, this is the actual console that the urologist is actually mapping what we want the robotic water jet to go through and destroy that prostatic tissue before the urologist actually goes in a similar manner as the initial surgery, the TURP, and whatever blood vessel is bleeding significantly, we can cauterize it, and that way we can limit how much energy we're putting into the patient's prostate and bladder neck, which is beneficial in a way that the less energy, meaning electrical energy or cautery energy that you use, we have the expectations that the less symptoms from like urinary urgency or frequency the patient may develop after the surgical intervention. Okay, so moving on from the prostate to the probably the second most common pathology that we see, or probably the most common pathology that we see, is stone disease. Stone disease, when it comes to medical management, can be as simple as just educating the patient in appropriate diet and appropriate fluid intake, as stone formers should be trying to aim to drink and void at least 2.5 liters per day. And then when it comes to dietary intake, we want them to limit the salt intake. We want them to limit the oxalate intake, and this can be done just by purely just adjusting your diet. So, for example, on oxalate-rich foods such as nuts, spinach, um, chocolate, all of those things. When a patient is a recurrent stone formers, those are things that they need to watch out for and not abuse in their daily routine. Um, when it comes to surgical management, this is another area in urology that we have a very ample variety of tools to assist the patients with. Now, the least invasive way that requires no instrumentation of the patient is what we call the extracorporeal shockwave lithotripsy, which is the upper right corner picture, this right here. And with this technology, what we do, we triangulate the stone and then send ultrasound shock waves that fragment the stone, and then the patient has to pass the little sandy material on stone fragments. The benefit of this type of procedure is that there's no instrument that needs to go into the patient. The downside to it is that if the stone fragments that are left behind are big enough, can be big enough that the patient may be uncomfortable passing them, and about 15% of patients may require another surgical intervention because they can't pass the stone fragments. Going further down the line to a procedure that is a little bit more invasive but is equally as safe is the picture on the left lower corner, which is called uroloscopy. In this type of procedure, we use a very small camera that we put it in through the meatus and guide it all the way into the ureter, and through that camera we pass a very different laser fibers. The two most commonly used one are the holmium fibers and the thulium fibers. With these fibers, and as you can see on the bottom picture, especially the holmium fiber is what we call a contact fiber. So what it does, whenever the laser fires and it comes into contact with the stone, it slowly starts evaporating that tissue, that stone, until we get it to a small enough size that we can either pass the little basket that you see on the upper part, part of that picture, to grab it and physically remove it out of the patient, or dust the stone down to fragments that are smaller than 1 milliliter. Sorry, 1 millimeter. So those fragments the patient should be able to pass with minimal to no discomfort afterward. Now, further escalating how in terms of how invasive surgeries are, we have the right lower corner picture, which is called a percutaneous nephrolithotomy. In this type of procedure, this is usually reserved for bigger stones, meaning a stone over 2 centimeters, 2.5 centimeters, that will require several more than 3 less invasive surgeries to achieve appropriate stone clearance. In this type of procedure, we make a flank incision and then dilate a small tract from the patient's flank all the way into the kidney, and then either use what we a shock pulse machine, which is a metal wand that vibrates very rapidly, and this causes this fragments the stone and then suctions the stone out. But we can also use the same technology in the ureteroscopy and pass a laser through the equipment and fragment the stone that way. When it comes to all the surgical interventions, the one that obviously carries the highest risk is the percutaneous nephrolithotomy, because we are literally making a small incision in the kidney, which, as we all know, is one of the organs that receives the most blood per minute in the body. So there's always a risk of requiring a transfusion after this type of surgery, although that risk is low. Then going from the kidneys and the stones, we're going down to the bladder. So when it comes to overactive bladder and urinary incontinence, there is a wide variety of medical management options, including anticholinergics and beta-3 agonists. And when it comes to stress urinary incontinence, the main or the least invasive way to treat mild to moderate stress urinary incontinence is what we call pelvic floor physical therapy or pelvic floor strengthening exercises, such as the Kegel exercises. When as in any approach in urology, when medical management is not achieving the goals that the patient has set for themselves, or their quality of life has not improved with less invasive management options, we have surgical options, okay? When it comes to overactive bladder or urge urinary incontinence, we have a wide variety of treatments, ranging from a procedure that can be done in the clinic, or it can be done in the operating room under light sedation, which is injecting intravesical Botox inside of the bladder to limit bladder contractions. We have the other procedure that can be done in the clinic, which is the peripheral tibial nerve stimulation, that basically stimulates the S3 nerve, and that controls bladder contractility. Sacral neuromodulation is another option that basically does the exact same thing as the peripheral tibial nerve stimulation, stimulating the S3 nerve to limit bladder hypercontractility. And as a last resort for patients that have what we call a very low capacity bladder with really unresponsive overactive bladder symptoms, we have surgical techniques such as bladder reconstruction or urinary diversions, in which we use a piece of bowel to either create a new bladder or create a channel that is connected, or a stoma that is connected and placed on the patient's right lower quadrant, to which both kidneys are attached, and they end up voiding into an ileostomy bag. When it comes to stress urinary incontinence, if pelvic floor physical therapy is not achieving the goals that we want, the two most commonly used techniques to help patients stop their stress urinary incontinence is what we call urethral sling procedures. The most commonly used one is the mid-urethral sling. And we also have the urethral bulking agents, and I will show you a few pictures after this, okay? So on the left upper corner, that's the tibial nerve stimulation. As you can see, it's a very small needle that is placed just adjacent to the tibial nerve, and this sends an electric signal that then goes all the way to S3 and helps control bladder contractility. On the right upper corner, that's the sacral neuromodulation. As you can see, we place a small guide down past and along the nerve, and those electrodes send electric signals to the nerve to control the bladder contractility. When it comes to the stress urinary incontinence, we have the most commonly used procedure, which is the retropubic mid-urethral sling, which is a sling that is made out of a non-absorbable material. And since it comes in a mesh, let's see how I can say this a little bit better. It comes in a mesh pattern. What we do is place it just below the urethra and allow the tissue of the patient to scar into the sling to provide that support to the urethra, and allow the patient to not have voiding accidents or stress urinary incontinence whenever they perform any Valsalva maneuvers, such as coughing, sneezing, or lifting heavy things. When it comes to the bulking agents, as you can see in the right lower corner, is a minimally invasive procedure that is done through the urethra, in which we inject a bulking material at the bladder neck to create a coaptation. And basically what that is leading to a degree of bladder outlet obstruction that is normally a good option for patients that have a pathology that is called intrinsic sphincter deficiency, meaning that their sphincter is not collapsing enough to be able to hold the urine inside of the bladder. When it comes to urinary tract infections, the main thing that I want to focus on is, as a urologist, what we mainly focus on is recurrent urinary tract infections. And the most important thing, especially in younger patients, is antibiotic stewardship. Because the worst thing that can happen to a patient is getting antibiotics without knowing what the urine culture is and the cultural sensitivities are, because this exposes the patient to develop antibiotic resistance, and it leads to us as urologists to run out of tools to be able to help the patient further down the line. So always, when you have a patient that comes into your clinic with a complaint for a urinary tract infection, make sure that a urine culture is obtained prior to starting any antibiotics. So when it comes to erectile dysfunction, we have the medical management with the most commonly used drugs, which are the phosphodiesterase 5 inhibitors, such as the Viagra, the Cialis, or the Levitra. These are medications that what they do is they increase the cyclic GMP, and this leads to a lower intracellular calcium, which leads to vasodilation, and this leads to be able to get better blood flow into the pinna, into the corpora, to allow to achieve an erection. If medications by mouth are not working, we always have the options such as injectable medications, so injectable vasodilators. And we also have a suppository type of medication, or a gel type of medication, that is also a vasodilator that the patient puts at the tip of the penis, and that allows improvement in the blood flow into the corpora. When medical management is not getting the patient to an erection that is strong enough to penetrate and reliable to finish intercourse, there's always an option of a penile prosthesis, which is the picture that you see on the right bottom corner. This is one of these samples, because we have this, which is a three-piece inflatable prosthesis that has the reservoir, the pump, and the cylinders. But you have a two-piece inflatable prosthesis that doesn't have the reservoir, or the intra-abdominal reservoir, and you have some a what's called a malleable prosthesis, which is like the older version that is not used as frequently anymore, but is still used in certain cases. Okay, so prostate cancer. When it comes to medical management, the main purpose of medical management when it comes to prostate cancer, especially specifically when we're talking about metastatic prostate cancer, is what we call androgen deprivation therapy and anti-androgens. Well, and this is mainly used, like I said, for metastatic prostate cancer. There are some patients that do get the androgen deprivation therapy if they have unfavorable intermediate risk prostate cancer or high risk prostate cancer while they're undergoing management with external beam radiation therapy. So when it comes to surgical management for prostate cancer, the most commonly used technologies is like we saw previously, the Da Vinci robotic console, or the single port robotic equipment. But we also have focal and percutaneous therapies, as you can see on the left bottom corner. This is what's called irreversible electroporation of the prostate. This technique is usually used when you have a lesion on just one side of the prostate and it's a small amount of cancer, as this technique allows the physician to have almost pinpoint accuracy. As you can see, the two small rods are being placed inside of the prostate, and in between those two rods, there an electrical current goes through there, successfully killing off the cancer. On the right upper corner, we have the high intensity, high intensity frequency ultrasound, which is an ablative technique. And on the lower part, we have the cryotherapy. And you'll see that this type of cancer management is almost ubiquitous. And when it comes to urologic cancer, because as we'll see not this one, in renal cancers, obviously we have the surgical options for robotic and open surgical excision of the mass, but if there are some patients that are good candidates for what's called percutaneous approaches. In the first picture, we're seeing a high frequency ablation of the mass right here, and on the lower one, we're seeing a cryoablation of the mass. When it comes to bladder cancer, medical management of bladder cancer is mainly done after you have underwent surgical intervention. And this is because you need to obtain a pathological analysis and a depth of invasion of the tumor to stage the patient and risk stratify the patient to guide what is the best next step in management. So, but as you can see, the most commonly procedure performed for for bladder cancer is endoscopic surgery. As you can see in that picture, is a resectoscope is placed through the penis, and you see a small bladder tumor on this right lower picture. And what we do is we systemically carve out this tumor both superficially and with deep samples to ensure we get appropriate depth and negative margins, and also make sure that we obtain muscle in the specimen to ensure to be able to risk stratify the patient and guide them into what is the best next step for them. And I think that concludes my presentation. If you guys have any questions, feel free, and do not hesitate.
Thank you so very much, Dr. Sanchez-Correa. What a great recap of all the technologies that you have at hand in your toolbox in order for you to treat so many different conditions. Yeah, there must be some questions that the audience has for us, but I wanted to ask you, I'm actually curious, when you spoke about the nephrolithiasis or kidney stones rather, are we still treating some of these kidney stones, specifically the ones that are treated for uric acid with bicarbonate, as we used to do before? Or is there an alternative for it?
What's being reported in the literature. So there's a few ways that we can know if the patient may have uric acid stones. Obviously, if we treat a patient and get a stone out and send it for analysis, we can confirm that they have uric acid stones. But if we get a CT scan and the density of the stone, it shows that it's a very a very soft stone, and the patient has a urinary acidity in like a pH of 5.5, that tells us, hey, this may be a uric acid stone. So what we need to do is alkalinize that urine, and it's been seen that if the whatever portion of the stone was uric acid, it may dissolve within 3 months of that urine alkalinization. So yeah, we still use sodium bicarb, we still use potassium citrate.
Wow, that's good to know that still at least a very cheap alternative to
Yes.
treating to treating this. And what about the cysteine? Are you still using penicillamine for it?
So yes and no, because
Uh-huh.
penicillamine has a lot of liver toxicity, and
Yeah,
it can also lead to anemia and other thrombocytopenia. We use something that's called Thiola. Okay, that is very similar, has very similar side effects, but it's a lot more tolerated than in penicillamine.
I see. I see. And in addition, you did mention obviously that diet modification continues to be the number one recommendation for these patients. Of course, smoking cessation is still in the list of things to stop or provide the patient in order for them to at least get some, some of their symptoms gone away.
Yeah, and not only that, it is also obesity has been related to
Do
increasing
it,
the risk
yes.
of stone formation. So we always counsel the patients on appropriate diet and physical activity, and hopefully getting that BMI a little bit lower.
Right, right. There are so many factors that actually can play an important role in this. As a matter of fact, as a quick parenthesis, I don't know if you read that at the beginning of the year, there was a report that says finally the United States has curbed the obesity epidemic slightly. And most likely it's because of the GPL-1
Yeah.
Ozempic, all these families of new medications. But anyway, I digress. You mentioned something extremely important, and I think that it is incumbent upon us to actually make sure that we highlight it again for our students. And it's the fact that the antibiotic stewardship continues to be the rule in clinic. It is a must that we have this instilled in our new practitioners or anybody that joins a practice, that not because a patient is requesting antibiotics, you're going to give it to them. And you did
Correct.
mention very clearly that before you start anything, you need to get a urine culture, you need to send it to laboratory, and then you determine the sensitivity for a particular antibiotic. So I just needed to mention that because this is something globally that we are suffering because of the overuse of antibiotics. Doctor, we have a few questions, and one of which comes from Joshua Kohina, and he says, What can you tell us about the potential mechanism by which poor cardiovascular health might have an effect on exacerbating overactive bladder symptoms?
So when you have cardiovascular or
Cardiovascular health.
so when you think of it from from a cardiovascular standpoint, I don't know if there's any direct correlation, but more from a peripheral artery standpoint, because as we all know, all the nerves that control our organs are dependent on very small arteries feeding them, right? So if you have significant peripheral artery disease, that can definitely affect your nerves. That's why patients develop um, something that is called diabetic uropathy, and that is because the bladder gets to the point that it no longer feels, and when it feels, it just gets full with urine. It just stretches and stretches and stretches, and that's what we call a flaccid bladder. That's what's normally seen on diabetic patients and patients with peripheral artery disease, that they can have bladders that hold 2, 3, 4 liters, and they have no sensation, when a normal bladder normally holds about 500 cc's to 450 cc's.
Interesting. Andres Rojas wonders, what do you consider the biggest challenge in early prostate cancer detection, and what emerging biomarkers could improve the PSA accuracy?
So yeah, so as we all know, the basic test that we all get is it's just the PSA. Okay, so nowadays, what is recommended is for males that have African American heritage to start at around 45 years old, and for guys that are of white descendants to start at 50. And normally, so we use the PSA, but we also have the free PSA, which is a good extra tool that we use, especially when a patient has an elevated PSA and we've had several biopsies or several MRIs and nothing comes back as positive for cancer. You keep an eye on the free PSA as an extra tool. You can use the ISO PSA as well as an extra tool to guide you in guiding the patient. And hey, do you need a biopsy? Do you need a repeat biopsy? Other tools are more like nomogram tools, like the that we can counsel the patient based on their PSA, their free PSA, their prostatic volume, their family history, and prostate size, and tell them, hey, you have a 10% risk that you have clinically significant prostate cancer, because that's a very important distinction. Not every prostate cancer necessarily needs treatment. And because if you have a low risk prostate cancer, you may be a good candidate for what's called active surveillance. And currently, both the AUA, the American Urologic Guidelines, and the European Urologic Guidelines recommend, if you have low risk prostate cancer, the first option for you should be active surveillance.
That's great, Doctor. Ligia has a beautiful comment here. She says, thank you. Very grateful for this excellent conference. So thank you, Ligia, for participating in today's conference. Andres is saying, from your perspective, what is the most promising advancement in urology that you expect to see implemented in clinical practice in the next 5 to 10 years?
That is a very, very interesting question. And now I can point to something that is currently happening. So our equipment, as we progress, are getting smaller and smaller and smaller. So for example, like the stone procedure, the percutaneous nephrolithotomy, we used to have to dilate a patient to what we call a 30 French. Nowadays, we can dilate down to just a 20 French, which leads to a lot less pain after surgery, leads to a faster recovery after surgery, and it significantly decreases also the risk of bleeding. So I think, again, like I said, for urology, the beautiful thing about urology is that we're always in the forefront of technology. So getting our equipment smaller and smaller, but without losing the accuracy of the picture and the flexibility of the equipment. I think that's what we need to keep trying to thrive to, because that just leads to faster recovery.
Indeed. As a matter of fact, there are several technologies that you can actually use on patients that require radio oncology treatments, such as hydrogel and other protectants for rectum
Correct.
strictures and so on. So there is a lot and more to come, my dear future doctors. Ileana Sarmiento is asking, is it possible to get a false positive in PSA while using some kind of a medication? Is there any medications that will alter the PSA?
So when it comes to medications, I can't say that I see any PSA being elevated, falsely elevated or lower. One thing that you do have to take into account is there's been some reports that if you're an alcoholic patient, your PSA may be falsely lowered. That is one thing that is very rare to see. At least, and I've only seen maybe one or two studies reported on it, but it's something to keep an eye on, because the majority of the PSA, so when it comes to medical management, the only thing that I can think of right off the top of my head is if you place a patient on testosterone replacement therapy, you expect that patient for their prostate to become a little bit larger, just because you are feeding the prostate, you're giving the prostate more food for the fire. So the bigger the prostate, the more PSA we expect to see on the blood work. And from a management standpoint, for example, if you use dutasteride or finasteride, which do the complete opposite, which is they limit the dihydrotestosterone supplementation to the prostate, if you are on a dutasteride or finasteride for at least 6 months, we expect your PSA to be about 50% of what it really is.
50%.
Yeah, so if you're on dutasteride for 6 months and your PSA is 2, your real PSA is 4.
Okay. I'm writing that because that's interesting to to keep that in mind. Doctor, you also talked about another part of your specialty, which is neurourology, and that is, of course, up and coming as you develop new technologies and new devices. You can actually think of the possibility of sparing some of the issues that perhaps the prostate cancer victims will have to undergo. Is there any new things that you can share with us in regards to the surgical intervention for prostate cancer to spare the nerves?
So yeah, so right now the gold standard of treatment is what we call a nerve-sparing prostatectomy. Okay, that is that as long as it doesn't compromise oncological guidelines or oncological principles, every single patient should be getting a nerve-sparing radical prostatectomy. Okay, that doesn't mean that the patient is going to be complication free or symptom free, okay? Because even with a nerve sparing approach, about 15 to 20% of patients can develop stress urinary incontinence, and depending on what papers you read, anywhere from 20 to up to 40% of patients can develop erectile dysfunction.
Mhm.
Okay, and a lot of the time it's not because of nerve damage, it's more from a what's called neuropraxia. When you manipulate the nerve kind of basically goes numb,
Mhm.
and the normal recovery for both the stress urinary incontinence and the erectile dysfunction is about 6 months. But it can take, especially for the erectile dysfunction, it can take 12, 16 months and even longer.
Okay. One last question, and it's for Dr. Robleto, and she asks, do you think that in medicine in the future, we'll be able to work hand in hand with nanotechnology?
With nanotechnology, I mean, I don't see why not, because we're already using vectors, like viral vectors, to get medicine to
Mhm.
treat cancer. So I don't see why that wouldn't be an option.
The sky is the limit when it comes to medicine. We're just scratching the surface. The fact of the matter is that the last 20 years has been somewhat of a revelation for the medical field, and now we are walking in the midst of incredible scientists that are developing phenomenal things, and we're in the midst of that. Dr. Sanchez-Correa, we can have you and keep you for hours because this is a fascinating topic. We are so thrilled that you have decided to join Baptist Health, and we're looking forward to having you in future conferences, hopefully visiting some of the countries that are participating today. And to all of you, thank you so much for participating. We really are thrilled that we can bring these lectures to you and share the expertise of our luminaries directly with your universities, and especially with every single one of you. Phenomenal questions. Thank you. I would like to invite you to our next video conference, which is going to take place on May 21st of this year, of course. And if you do have additional questions, or if you want to ask any questions to Dr. Sanchez Correa, we'll be more than happy to provide him with your questions. But please send them to BHIWebinars@baptisthealth.net. That is baptisthealth.net international, or BHIWebinars@baptisthealth.net. Dr. Sanchez Correa, you're brilliant. Thank you so much for your time.
No, pleasure. Thank you. Thank you for the opportunity.
It was a pleasure. Thank you, everyone.
Bye.